Thank you, Shaili, Divya, and Ravi, for two reasons. One, to think of a round table on a rectangular table. Yeah, we will live in an era of paradoxes, and we have to create and we have to visualize round tables in a rectangular framework. And I hope what Mr. Anil Shru told in the beginning proves my experience. In this era of trying to find out operational efficiency in healthcare sector, sometimes you lose sight that healthcare is a broader framework in the social development framework. If we have to achieve health status in a developing society in India, we tend to presume that the intervention will lie in the health sector, which is the biggest myth in the medical education in our country. Most important intervention which will transform the healthcare scenario in the country, surprisingly, and it's available in all international documents, leave aside the national documents, is the nutritional deficiency, the malnutrition that is prevalent, whether in utero or outside after birth. Yet, the interventions and all the arguments in the public fora that I hear are focused on intervention in the health sector. So if we are going to talk on operational efficiency in the healthcare sector, we need to move away from healthcare-centric prescriptions or descriptions or analysis to non-health sector interventions, descriptions, analysis, and understanding and learning. That would be one. That myth, and this over the last 32 years of my graduation from Maulana Azad Medical College in New Delhi, I think after 32 years of my graduation, I feel that is the biggest learning I've made in 32 years. So I would say 5 major paradoxes we need to tackle, and this is an indication to SAP that the myths in the medical textbooks and myths and realities are to be balanced. India is a land of paradoxes. It shall remain a land of paradoxes. The 5 major framework, or the 5 corners of this framework which I feel is important at this round table, if it becomes a round table in reality, Ravi. Facilitators versus providers, which is the right mode of provision of healthcare in our country. We need to, as a government or as a provider, whether in the public sector or the private sector, we need to be facilitators or we need to be providers. I have a feeling that we have always thought ourselves to be providers rather than being facilitators. As if everything is going to be happening within the state government health department, or as if everything is going to happen within the central government health department. As if nothing happens outside, which is a thing to be thought about. I'm not answering any of these paradigms. Second framework we need to address is indirect financing versus direct financing. When you talk of operational efficiency, it cannot happen unless we clear this paradox of whether indirect financing will be more efficient or direct financing will be more efficient. I have a feeling all through these last 60 years of our structured planning process, we are focused on direct financing, while actually operational efficiency may lie through indirect financing routes. RSPY is a wonderful example of the success of this model. Third framework which I would like you to consider is regulating versus executing. Out of these two, which appeals to you more? Whether you need to be an outstanding regulator to be effective, to achieve operational efficiency, or you need to focus on more efficient execution of the business of healthcare. I have a feeling if we really have to succeed and achieve operational efficiency, we need to focus on how we need to create a structure which is outstanding in terms of regulatory framework rather than outstanding executioner. Because operational efficiency will happen if we have a single-minded focus on creating a good regulatory framework and structure on the ground and in terms of national and regional and local planning process. Fourth, I have already mentioned health-centric versus non-health-centric planning process. I have a feeling in Indian context where the major causes of illness, as Mr. Anil Swarup mentioned, are not directly related to health per se as is understood in the Western text, which is disease-centric. In our part of the world, it is more of health-centric, which leads to more of health status-centric, not disease-centric, which ultimately leads to better efficiency. Because we have little money, we need to focus on something which can really change the acquisition of disease rather than acquisition of prevention from disease, or managing a disease process that is already established due to inherent structure of the human being, that is malnutrition and other environmental factors. Poverty is one of them, food is another, education, lack of education is another. Money for money, these interventions, whether it's global analysis or people in the health sector or in the finance sector, IMF or World Bank, economists have underscored this point. Tackle these basic issues first and then tackle other issues later. If we need to only focus on cancer or cardiovascular illnesses, I have a feeling that we are not putting our money where public money should go. The fifth kind of paradox which I have always been facing the last 30 years is integrative versus discrete centric entities model of delivery of care. If you see the history of health sector reforms or health sector implementation all across in the center of the states, even in corporates, it has always been fashioned around certain disease or program specific projects which last for 5 years, and it is recrusted into another program after another 5 years, and the cycle goes on. The process of integration, which began in 2007 in India through the NRHM, will ultimately will reach its natural progression, so to say, with the National Health Mission in the next 5-year plan, if it is actually accepted on the ground. There's a lot of debate at the moment in terms of whether we should have two vertical national rural health versus national urban health missions, instead of having a unified national health mission. The country is divided artificially into so-called urban and rural, while actually the country resides in the grey zone, that is between the rural and urban, because India as such is transforming. The real story of health sector reforms and actual execution and health status improvement will occur in tier 2 and tier 3 towns and cities. If you see the growth, economic growth, if you see the health status improvement in the last 30 years, it has actually happened in tier 2 and tier 3 cities, and in the so-called artificial divide of urban versus rural. These tier 2 and tier 3 cities they can be ignored at the cost of so-called very rural or so-called tribal and unreachable versus very urban metros, which have population more than 20 lakhs, say 40 lakhs. And they are very aggressive. They have all the media is over there. Everything gets noticed. The ultimate sufferer is the tier 2, tier 3, where actually, as ISBY has shown, that health sector is functioning there. Because if you analyze the health institution in the country, surprisingly you will find a shocker. Most of the hospitals are individual doctor owned, not even a businessman owned. Leave aside more than 30 beds. International definition of a hospital is 30 beds. You can't call a hospital as a hospital if it does not have 30 beds. But most of the hospitals in our country are actually less than 30 beds. And they are labeled as hospital. Everybody perceives them as hospital, or somebody would call it nursing homes, somebody would call it some name, but they are actually perceived and advertised and utilized as hospitals. And they run on a very low occupancy rates. So both are the losers. The person who is running, who has invested his lifetime savings, his background, most of the individually owned nursing homes are from not publicly financed. They are financed from the pocket savings of that doctor, which is a worst way of investing public money for public purpose, or individual money for public purpose, for that matter. If this transformation is to actually progress and operational efficiency has to occur, this will not occur through so-called 5 major public limited companies in the health sector, namely Fortis, Manipal, Apollo, or Max, or other new chains which are coming. This will happen only through a process where these small, individually owned, existing tier 2, tier 3 cities located hospitals actually getting money for expansion, and a tool like RSBY for its occupancy to increase, and actually transforming the whole world into a place where a person knows that my health is assured, and then he can start saving and investing for prevention of health, which is ultimately the real transformatory process. If the individual here is assured of health without investing his own money, or even if he invests, he is assured that there is insurance available through a public funding mechanism, that money saved, say 30,000 of RSBY, invested by an individual in terms of savings, in terms of education, in terms of livelihood, in terms of actual prevention, in terms of, say, better quality of food, more education in terms of better knowledge about prevention from disease. That is the real value, and that is the real GDP, which ultimately makes the progress from a developing to a developed society. The last paradigm which I want to put across this round table, and I don't want to be prescriptive, is the model of learning and doing versus teaching and getting done. These two paradigms, ultimate success lies in learning and doing. Having traveled all the so-called 6 continents of the world and the seas lying between them, I feel anybody who says I know is need to learn a lot what he does not know. He does not realize what he does not know, because the world is changing every day, it is transforming. How can we say we know? We learn and we do from what we learn. It's foolish to talk that I am a teacher and I know what I'm teaching. I've become a teacher because I want to learn. I want to improve myself through the process of interacting with the students. That process, I think, is the model which is required to achieve operational efficiency in health management. You don't need to be a health expert, you just need to be a simple citizen of this country to make an effort in improving operational efficiency as civil servants have shown. Last point I want to make, this forum for consideration of the roundtable members is actually when we travel all across the country, the lessons come through sheer power of observation. It does not come through textbook or research studies in social science or economics textbooks. It comes through actual interaction with the people in the rural hinterland. This I came to know very early. 1983, I was recruited by the National Institute of Health and Family Welfare for assessment of laparoscopic sterilization in the state of UP. And I just passed out 3 years just after my graduation. I was specialized in pediatrics and a pediatrician. And the task given was to travel to village, medical college, district headquarters, taluka headquarters and tehsil headquarters of 13 districts in UP over a period of 6 months. For a medical graduate who has studied and graduated from so-called one of the best medical colleges, to travel to these areas on a random basis. I could not predict which village will come and how far that will be. Over the next, say, 6.5 months, it was an eye-opener. To travel to reach out to a lady who was operated 2 years back in a medical college hospital, say Jhansi, and her address comes out through random selection in a village where I had the last jeep which the district magistrate was providing could reach, and then I have to take another vehicle or say a horse cart or whatever, but I had to walk 10 kilometers on 2 occasions also, because that lady was residing there. And this is 1983. And every record of the feedback, I had to actually see that the work, with the social scientists with me, are actually recording the reality about how that lady traveled to get herself operated. Mind you, it was laparoscopic sterilization way back in 83, and I had to assess the quality. Centric is one surgeon operating in a medical college in a district hospital, mostly the teaching medical college hospital in UP. It's a lesson in its own right. If that lesson SAP wants to learn, it will not be learned sitting in Bangalore. It can never be learned in sitting in Bangalore. One needs to travel in the rural hinterland, right from metro to tier 1 to tier 2, tier 3 cities, and they are cities and towns in their own right. And ultimately travel to the person who is actually not having any resources of livelihood, leave aside land or leave aside, I would say, even say food. If we have to reach there, then I think, and if we are able to reach there through ICT, then actually we have a tool for transforming India and ultimately achieving the so-called operational efficiency in healthcare management. Because that is real healthcare management. When we say health, it is not disease management. Health includes a bigger term. Take up any definition of health, whether it's WHO or Government of India or Planning Commission or any expert for that matter. I've taken a lot of time, but I think the points made were essential, and if I have tread on certain soft toes, pardon me for that. Thank you.